Hey, this is Tiffany Kon with the Master's Social Work Program at California University. I am an intern at Monongahela Valley Hospital, and I'm working with Christina and Paige, and this is our reverse case study for Strike a Spark conference.
I am Paige Weber. I am a clinical mental health master's student, and I am currently an intern at Family Behavioral Resources.
Hi, I'm Christina Johnson. I am an MSW student. I'm currently doing a intern work program at Kane McKeesport. All right.
Our client that we have picked for our reverse case study, his name is Joseph James. He's a 63-year-old male who was brought to Monongahela Valley Hospital, also known as MVH. He was brought by ambulance. Mr. James' initial complaint was unable to ambulate. During his visit to the hospital, he also complained of shortness, breath, and a cough. Our emergency room physician had ordered a COVID test, and it was found that Mr. James had tested positive for COVID-19. After the emergency room diagnosis, Mr. James had been admitted to the COVID unit at Monongahela Valley Hospital. While in the COVID unit, Mr. James had met with me, the social worker who was assigned to his case. I had completed an initial assessment with Mr. James about his current living situation, supports at home, along with any current or past services that he had had, including visiting nurse agencies, Meals on Wheels, community transportation. Mr. James reports that he lives with his wife and grandchildren, and that he is the only one working in the home and able to support his family. With him now in the hospital, he is unable to walk and has made his life extremely difficult. During his stay at MVH, he was started on the IV medications for the COVID-19 diagnosis. His condition had deteriorated. Mr. James was evaluated by our physical and occupational therapist, and it was noted that Mr. James would need more therapy to get him strong enough to return home with his wife and grandchildren. When initially speaking with Mr. James, he had refused a skilled nursing facility, but learning that his condition had worsened, he was compliant and agreed to referrals to be made to a skilled nursing facility. I was able to find a rehab for Mr. James to help along with his recovery with COVID, and I referred Mr. James to Christina at Kane.
So Mr. James was admitted to Kane for a short-term stay, and he was just going to be on our COVID recovery unit. He did say when he was admitted that he was the sole provider in his home, and his COVID-19 had taken longer than expected. The more time he spent out of work, he pretty much fell behind on his utilities and his rent, which put some stress on himself and his family. So I assisted him in contacting some agencies to help resolve these matters. We made a referral to Blueprints for rental and utility assistance. We gave Mr. James some information on his discharge instructions. Well, we just put that information on the discharge instructions just to make sure he had it in case he forgot or it got lost or. So to address the food insecurity, he was directed to the Greater Washington County Food Bank. At the end of his stay, he reported that he was increasingly depressed and had anxiety symptoms. So to make sure that he was cared for in the community, we made a referral to Paige to follow up with him
So after Christina referred Mr. James to his local community counseling center, he met with me to talk about feelings he's been experiencing surrounding his recovery in the COVID-19 unit of his hospital. Um, when we met for the first time, we completed an intake assessment, which consisted of some referral information, previous resources used, emergency contact and PCP information, as well as completing the PHQ-9 scales as well as promise scales to assess for levels of depression and anxiety, as well as the creation of a treatment plan. During the assessment, Mr. James did report he was feeling increased feelings of depression due to being the sole provider of his family and the stress that comes along with that after being in the hospital for so long. He also reported feelings of anxiety surrounding the virus itself and how it could affect him again or his family. He shared that he had previously been referred to outside resources to assist in his transition back into the community, like utility assistance and food security programs. And to assist with this, I helped him get in touch with a case manager to help him keep all of his resources organized. Mr. James stated that he felt helpless and ashamed of needing his resources. He didn't want anyone to know that he couldn't take care of his family. After getting this information from the initial intake, we created a treatment plan together to outline the 3 main goals that Mr. James would like to work on while in counseling services. The first goal that we discussed was to work to decrease depressive symptoms related to stressors of being the sole provider of his family. We also decided to work on decreasing feelings of anxiety surrounding the virus itself, as well as processing his feelings of helplessness with seeking financial assistance programs. To work towards some of these goals, it was determined that we would use CBT-informed interventions to help him process his feelings with emotional regulation while learning and implementing positive coping skills. We also decided to utilize DBT-informed interventions to help with distress tolerance. We worked on things such as negative thought processes and should thinking, while learning positive communication skills to talk through the different things he's been feeling while he is in contact with other resources as well. As I said in the assessment, he completed a PHQ-9 assessment to determine measurable levels of depressive symptoms. We also completed the PROMIS scales, and this assesses for levels of anxiety, peer support, companionship, and self-esteem. Mr. James and I will complete these together every 90 days to help determine progress. This will help us show when Mr. James will be ready for discharge from community counseling services. And we'll recommend him for discharge when he shows significantly decreased scores in his PHQ-9 and PROMIS scales, as well as when he self-reports that he feels he has made significant progress towards his goals. Upon discharge, I will continue to recommend that he keep in touch with his PCP regarding his recovery and symptoms, as well as keep in touch with that case management program that we talked about before, just to help him keep his resources as long as he needs them. And that is the end of our presentation. Thank you for listening.
Thank you.
Thank you.